All right, let's start today with just a quick look back to the exam right before break there. Lots of A's on the exam. So once everybody took it, the mean was a 73. So I actually added 2% to everybody's score. I don't know if you noticed that on Blackboard. Double check my math. I was doing 130 of them or so. So make sure I gave you your extra 2%. I wanted to go through some of the questions that were more commonly missed. This one, I think, was the most commonly missed one, and this was a tough question, so I'm not surprised. Exogenous antigens, remember, those are antigens that are outside of the cell. If it's inside of the cell, like some part of a virus, then that would get presented with MHC class 1. Remember, one hand raised, you're volunteering what's inside of the cell. So the endogenous ones get presented to by MHC class 1 to cytotoxic T cells. Exogenous antigens get presented by MHC class 2, and those are going to be presented to T helper cells that are going to help activate B cells, make antibodies. So that's a humoral response. Right, so you had to kind of jump through a number of hoops to get the correct answer there. This one we did mention in class, and this one I guess you had to read it kind of carefully there. That oily sebum gives you the hint that the correct exoenzyme here, I guess, is lipase. Again, that one was commonly missed. Interestingly enough, people that had that on the front end of the exam didn't miss it as often as the ones that where the order was switched and had it at the end. I don't know if we get fatigued and don't read things as well at the end. And then this one, complement proteins are considered part of innate immunity, but this method of activation requires aspects of adaptive immunity, antibodies, adaptive immunity. So remember, the classical pathway is the one that requires an antibody bound to the pathogen that starts cleaving that C3. So it was correct answer there. And all the following are possible benefits of fever, except yes, fever signal cells make iron less available. Yes, it increases the mobility of white blood cells. Yes, to some small extent, it inhibits the reproduction of pathogens. I made this one up that it increases the production of membrane attack complexes. So hey, if you can find that in the literature somewhere, I give you credit for it. But again, I made that one up. So. All right, so I am going to have office hours tomorrow. I'll be in here at least 9 to 11. I can be here kind of at either end of that as well. If that works, come in for you to come in and look over your exam. I always think that's helpful. Also, we're going to be finishing up chapter 19 today. So the homework assignments here this week and next week are not as extensive. There's no, big animations to watch or anything, I don't believe. So just kind of keep up with that. Don't leave it all till the night before the final. And I forgot to mention on Tuesdays, my apologies. I posted a document that I hadn't, it was not my newest tweaked, revised document. So those of you that were following along last time and I wasn't doing it in the same order as what your PowerPoints were, sorry about that. Again, I had posted my old, I think it was just called Streptococcus, and it had a ton of stuff on it, again, that I hadn't revised. So the right document, I think I posted it on Monday morning when I figured it out. But so if you downloaded it or printed it out before then, sorry about that. It's pretty much the same, some updated figures, and I changed the order of things a little bit, but should be pretty much the same. But again, I apologize about that. All right, so we were smack in the middle of talking about tuberculosis. So Mycobacterium tuberculosis, that's an organism that's acid fast. Remember, we talked about really just a couple of virulence factors there, that acid fast cell wall, high in mycolic acid, lipid, waxy cell wall, still has peptidoglycan, just like gram positives and gram negatives, but really some really distinctive aspects of that cell wall help it survive inside macrophages. The only other virulence factor that we talked about was cord factor. Kind of helps it, the bacilli kind of stick together and just makes it more likely to survive in macrophages. Complicated disease, we started going through that. Some people are able to clear it. Their immune system, they have a good response and they clear it even if they're exposed, but more often than not, it will go latent and form these granulomas that we call tubercles in somebody's lungs. It's kind of a stalemate between our immune system and the bacteria. Most people would never even move into secondary or activated TB. Only about 10% of individuals are going to, will that tubercle get ruptured. We also talked about that caseous necrosis that can take place, where the tubercle kind of has this kind of proteinaceous, cheesy type consistency to it. It's kind of a hallmark of tuberculosis. Once you move into these late symptoms here, we talked about that as we finished last time, the patient kind of appears to be consumed. So that's another name for tuberculosis is consumption. All right, kind of an old fashioned maybe name for it, but patients really tired, no appetite, they lose weight, they're pale, not getting enough oxygen to their body, their skin gets pale. And at this point, mortality is about 60% if it's not treated. So pretty serious when it reactivates. They're infectious. They're, remember, this is airborne. So breathing it out, coughing it out. It can progress then and will progress into third stage disseminated TB. Basically, those macrophages are moving through the body and it can affect pretty much anywhere in the body, kidneys, the bones, the brain. So at that stage, it's almost inevitably fatal without treatment. So we could write that in, pretty much 100% fatal, even with treatment, without treatment. Even with treatment, it's going to be fatal, maybe estimated 30 to 40% of the time. Okay, so, all right, so how do we diagnose? Because it can be latent, the diagnosis is complicated. Some of you may have recently had a TB skin test. So that's usually the first step to diagnose it. Somebody, you want to find out if they have TB or have ever been exposed to TB. They get injected a little of this tuberculin, which is sometimes it's called PPD, purified protein derivative from tuberculosis. And then we have to read that test 2 to 3 days after it's been injected to look for this delayed hypersensitivity reaction to that protein. And you have to, measure it to see what kind of a welt, if any, is there. A positive tuberculin skin test, though, gives us a little bit of information, but not really as much as we like. It either tells us that that patient has been vaccinated. We'll talk about the vaccine in a minute. They have they have had primary TB and fought it off. They have latent TB, or maybe they have active TB. So you're not really sure which of those it is. Sometimes instead of a tuberculin skin test, we'll do a TB blood test, one or the other. The blood test is a lot more expensive and it's not widely done, but basically you draw blood from the patient and then it's called a interferon gamma release assay. So sometimes you see that IGRA. Basically, we talked about interferon a few weeks ago. Type 1 interferon is interferon alpha and beta. That's the kind of interferon that virally infected cells release, and it slows the progression of viral infections. This is talking about interferon gamma, which is a type 2 interferon that T cells will produce when they're exposed to this a protein, a tuberculosis protein. I don't know exactly what it is that they use. So they take the blood, they add this antigen, this TB antigen to it, and if you get a rise in gamma interferon, then that's a positive test. So what does that mean? A positive interferon gamma release test, that means that the person either has latent TB or active TB. Okay, it won't test positive if you've just been vaccinated. So it's a little bit better test, especially in places where vaccination is common. Still doesn't tell us for sure if the patient's infectious or not. So typically, if you get a positive for either one of these tests, then the next step is doing a chest X-ray, where they're looking for the presence of tubercles. And I guess if you have latent TB, they're usually, I forget, higher in the lungs, and if it's active TB, it's lower. I believe I might have that switched around. Usually, if you have, say, a positive TB test, they'll do a chest X-ray just to rule out the fact that you have TB, and just look for it's clear. Because if you're seeing tubercles here, sometimes you can tell if it's active or latent, but usually if they see any tubercles, then they'll move on to do some microscopy from your sputum. So from patient's sputum, and that's kind of what they cough up, like deep, not just saliva, but what you cough up from your lungs. And they may do acid bath staining. So remember, we talked about that last time. An even better method is using fluorescent microscopy. So kind of think back to our kinds of microscopy: light microscopy, phase contrast, dark field. Those are the kind of really common ones. Using UV light is kind of a step up, a little better resolution, because UV light, shorter wavelength than regular visible light. And we can tag those fluorescent dyes with an antibody to only stick to a particular thing. So in this case, we have it stick to mycolic acid, and then only the mycobacterium or any mycobacterium would show up. So it's a really kind of clean method. If the bacteria are there, then a person has active TB. That apparently is a little bit cheaper. They also can do PCR of the sputum. Another method, apparently that's a little bit more expensive, so that it's not commonly done. Maybe it would be commonly done in this country, but not in developing countries where TB is common. All right, so it's kind of a lot of hoops to get through. Again, if somebody has been vaccinated, then it's a little bit harder. They almost always have to do a chest X-ray to just rule it out. A patient that does have TB, do you treat latent TB? Sometimes. It kind of depends. It depends where the patient lives and a lot of different things. Here, they probably would go ahead and treat latent TB, but it's a real process, the treatment process. Definitely would be treating active TB. The first drug that we had to treat TB, and this came out in 1946, was streptomycin. So this was a miracle drug, saved lots of lives. If you remember though, streptomycin is an aminoglycoside. And remember, the downside with aminoglycosides is the toxicity to ears and kidneys. Okay, so especially if you just don't get it dosed just right, the patient can experience some loss of hearing, even deafness. So today we don't use streptomycin unless nothing else works. Typically the cocktail given today is isoniazid. Remember, that targets mycolic acid synthesis, and rifampicin or rifampin, same thing, that targets RNA polymerase. and a couple others that I just decided not to burden you with. So 4 drugs typically given together, all with a little different mechanism, and that's hopefully to slow down the resistance of this organism. What was I going to say here? Typically, the patient has to take this cocktail of drugs for at least 6 months. So it's a long treatment. Remember, we said they're slow growing organisms. They're slow to die as well. And side effects are common. So things like nausea, headache, sometimes a rash, tiredness. It's a long time to be experiencing side effects like that. So, you know, there's a lot of the strategy. We found that people would be on their drugs for a while and they'd start feeling better and they would stop taking their drugs. And this, we think, has given rise to lots of different resistant forms of TB. So now they will often send somebody to a patient's house and watch them take their drugs, however many times a day that they have to do it. About 10% of TB that's diagnosed has resistance to at least some of those first line of drugs. So we call that multiple drug resistant TB. They try some different drugs like kanamycin, fluoroquinolines, maybe go back to the streptomycin. And about 1% of TB is extensively drug resistant, and that pretty much means that they have very little to work. Even this multiple drug resistant patients are taking about 20 pills a day. So, you know, it's a lot of drugs. We did have a new drug that came out about 10 years ago. It was the first new mechanism that has come out in over 50 years. It interferes with the mycobacterial ATP synthetase. So interferes with ATP production by mitochondria. But this is a scary thing, the whole drug resistance, because again, it is so difficult to treat already. And then, you know, we've got some strains where almost nothing works. So if it's hard to treat, how about a vaccine? Unfortunately, the vaccine is not that great either. We came out with this in 1921, the BCG vaccine. So it stands for Calmette-Guerin, the French men that developed it to the bacillus, Mycobacterium tuberculosis. So we've had this since 1921. I just read an article put out by the WHO that said, essentially, hey, it's been 100 years that we've used this vaccine. Why don't we have anything better? We need to throw some more money at this and try to figure something out. Part of the problem is we don't have a good animal model. We don't, apparently, I would think Mycobacterium bovis would be pretty close, but apparently that's different enough to human TB. That's part of the problem. But what is this vaccine? It's an attenuated vaccine. Basically, this is a strain of Mycobacterium tuberculosis. Actually, no, it's a strain of Mycobacterium bovis that has been grown in culture generation upon generation upon generation, that it has just somehow lost some of its virulence factors. And again, we haven't come up with anything better since then. It is pretty effective when we give it to children. The immunity only lasts somewhere between 5 and 15 years, and it's much less effective in adults, right? We want to protect everybody and not just kids. So unfortunately, protection is not good in adults. And individuals are going to test positive for that tuberculin skin test. So if they are vaccinated at one time, it just makes it more complicated to diagnose later on. That's one of the reasons we don't give it routinely in this country. But other parts of the world, it does, again, have some effects. All right. Any questions about tuberculosis? All right, we will move on then to chapter 20. And chapter 20 in your book talks all about gram-negative pathogens. All right, so we're going to start with a few gram-negative cocci. And then we have a gram-negative coccobacillus, and we're going to leave out the gram-negative bacilli because that's a lot of what you're working with in lab right now, and at least you get some exposure to the enterics like E. coli. So we're going to end up leaving those off. But gram-negative cocci, there's really only one genus of gram-negative cocci that causes disease, and that's Neisseria. These often present as diplococci, meaning pairs of cocci. It's kind of hard to see that from this picture here. Got another one that kind of shows that a little bit better. They are often considered non-motile. So remember, if we call something non-motile, that typically means there's no flagella. But sometimes we consider them to have what's called a twitching motility. And that just means, so here's the Neisseria. They actually have pili. I'm going to kind of draw attention to some differences from what all the other literature says than what your book says for a couple things with Neisseria. Your book calls these appendages fimbriae, and they are used for attachment, so that makes sense. But all the literature refers to these appendages in Neisseria as pili. So I'm going to call them pili. There's actually different kinds of pili. It's a type 4 pili that's a little bit longer that Neisseria actually have. So those pili can actually attach to other cells or structures, and then it's kind of like a grappling hook, like it can, pull itself closer to it. So it's kind of a very slow motility. It's not like runs and tumbles like we get with flagella, but sometimes that's considered motility as well. They're aerobes, and a good word to describe them is fastidious, meaning they're really picky about what they eat and when they will grow or not. So in other words, they're very difficult to grow in the lab because you have to have just the right conditions and you have to give them just the right media with all these different growth factors in it. So they're not easy to handle and work with in the lab. The two examples of pathogens that we're going to talk about, Neisseria gonorrhoeae, for me, the hardest microbe to spell by far, as if Neisseria is not hard enough, that E before I, don't ask me why, but gonorrhoeae, too many vowels and silent letters in there. Causative agent of gonorrhea, and Neisseria meningitidis, causative agent of meningitis. And we talked about several different pathogens that cause meningitis. This organism used to be known as meningococcus, and Neisseria gonorrhoeae we called gonococcus. So at some point we decided those two organisms were really closely related. We put them in the same genus and renamed them Neisseria gonorrhoeae and Neisseria meningitidis. Okay, so this is a meningococcal meningitis is what we would call that. All right, so let's look at Neisseria gonorrhoeae first. Causative agent of gonorrhea, second most common sexually transmitted disease behind chlamydia. And this is a true pathogen. So anybody that's healthy, that's exposed, is really likely to get it. Anybody can get it. It's not just an opportunist. Transmission, most often by sexual intercourse. So it's carried by sperm and bodily fluids. So males are more, due to differing anatomy, different areas are targeted. Usually the urethra is targeted in males, and in females, it's the cervix. And again, carried, since it's carried by bodily fluids, males, an infected male is more likely to pass it on to a female because it hitches a ride on that sperm. A female that's infected and the male's not is less likely to transmit it, maybe only 20% of the time. But the males, an infected male will transmit it, they estimate about 50% of the time to a female. Also mother to child. Okay, so a child born vaginally to a mother that has gonorrhea is most susceptible to an infection, an eye infection, gonococcal eye infection that can lead to blindness. Okay, so for that reason, all babies, whenever they're born, they're treated with eye drops, antibiotic eye drops. They used to use silver nitrate, that was a little more irritating. Antibiotics, I don't remember which one they use, is a little bit less irritating. They treat every baby that's born because oftentimes either women don't know that they're infected with gonorrhea or they don't admit that they are. So they just treat everybody. Also, dirty needles. So IV drug users, that's another potential transmission pathway for Neisseria gonorrhea. All right, virulence factors. Whether you call it pili or fimbriae, again, let's stick with pili. This is a little bit nicer picture. You can see the cocci in pairs there with these little hair-like projections that we'll call pili. Those pili are really important so that they can adhere to our epithelial cells and mucous membranes. Right. And there's two properties of pili that make it so successful in outwitting our immune system. And then by default, outwitting our ability to make a vaccine to gonorrhea. So one of those properties we call phase variation. Okay. So that just means that the composition of those adhesins, adhesin proteins on the pili is constantly changing. So adhesin our immune system has, these are very immunogenic, these outer proteins, these adhesins. But remember, it takes a while to get our adaptive immunity up and running. There has to be help from the T helper cells, all those different synapses made that we've been talking about. So once the antibodies actually get made that are going to hopefully bind to those adhesins and neutralize them, basically the composition changes. So a lot of organisms can do phase variation. Influenza virus is good at this, but they change over a period of months. That's why we need a new flu shot every year, because there's different strains just to kind of due to slow mutation. HIV is really good at that as well. Those are just due to mutation. Neisseria gonorrhea has specific mechanisms to do this, and it happens like every 10 to 12 days. So if you take upper level med bacti, Dr. Baxter loves to talk about these different mechanisms. I'm not going to talk about them, just tell you that this organism is really good at that. So it changes quickly. As soon as we get antibodies made, they're not good anymore. It has to make new ones to try to keep up. In addition to that, they can also, I knew I was saying this wrong. Changes to antigenic variation. Got goofed up there. Phase variation. That's when the organism can actually detach the pili. Okay, so they have a mechanism. So once the pili are made and then they change and start making new ones, they detach the old ones. All right, so due to both of these mechanisms, again, antigenic variation and phase variation, just again, our immune system's constantly trying to keep up, and the infection persists. We need antibiotics to get rid of this. Just a few other virulence factors. One exoenzyme, protease seems like a very general name for that, but secreted on the mucous membranes, that's going to cleave IgA, which, remember, is the isotype of antibody that's most prevalent on our mucous membranes. Does it have a capsule? This is actually a little bit of a complicated question. Your book says yes. Everything that I have read has said no. And that's complicated because we think that when it's in the host, the gonorrhea is not making a capsule, but we can induce it to make a capsule if we grow it on just the right thing in the lab. So it'd almost be better if it did make a capsule. Neisseria meningitidis makes a capsule, and we can make a vaccine that works against those capsular antigens. So the fact that it doesn't make a capsule, again, just makes it harder for us to make a vaccine there. It also has lipooligosaccharide. This is a variation of lipopolysaccharide. It just has a little shorter sugar subunit on it. But same thing, it has lipid A, which, remember, is the same thing as endotoxin. Okay, so with all gram-negative organisms, remember, that's part of their outer membrane and that cell wall. So I want to talk a little bit about endotoxin here before we move on. This is the figure right at the beginning of chapter 20. It talks about the effects of endotoxin. And we've mentioned this before. I like this diagram, though. It talks about how it can act to be one factor that activates complement. And I think it has to do with the alternative classical activation pathway, which we kind of said this is kind of complicated. This is normally splitting C3 all the time, and if a pathogen is present, endotoxin can help apparently activate complement, and the C3A and C5A, the C3A and C5A can increase inflammation. Endotoxin can also increase blood clotting reactions and lead to disseminated intravascular coagulation. That's just a way to say there's inappropriate blood clotting that takes place sometimes. We'll see that especially with the Neisseria meningitidis. Also, just acting on, it causes the release of lots of different cytokines that can cause fever and more inflammation that can even lead to shock. Remember, just blood vessels really leaky, blood pressure going way down. All right, so you get enough, endotoxin in small quantities, not too big a problem, a little fever, whatever. Too much of it is potentially deadly. And remember, that's released usually just when the cell dies. Whenever the cell wall breaks up, maybe a really small amount when the cell divides, but most of the time just when the cell dies is it released. So let's talk about some of the symptoms of gonorrhea, keeping in mind some of those virulence factors. Symptoms are very different depending on if we're talking about a male or a female. Males, burning while urinating. I've read that it's been described as like peeing fire. So sounds painful, pus-filled discharge. Because it's so painful, typically males will seek treatment. And the incubation time here is usually somewhere between 2 and 7 days after exposure. Okay, so they typically will seek treatment, get on some antibiotics, and get rid of it. Occasionally, it can be asymptomatic, and that's a problem because that can lead to just too much inflammation in the epididymis, and that can lead to infertility. And there is a potential for it to go systemic, so to be disseminated and cause all kinds of weird things like arthritis, and even be potentially deadly if it goes to the brain. So that's very rare, but the cases of that disseminated gonorrhea are for some reason going up a little bit. In females, symptoms very different. At least 50% of the time, females don't have any symptoms at all. And that doesn't necessarily mean it's not a problem. If they do have symptoms, it often will mimic either a bladder infection or a vaginal yeast infection. So painful urination or vaginal discharge. If females don't seek treatment, then it can lead to more serious complications. The organism can migrate up from the cervix up to the fallopian tubes, can potentially cause an ectopic pregnancy, can cause to fallopian tube scarring, which about 20–30% of the time can lead to infertility. So that pelvic inflammatory disease is not only caused by gonorrhea, but it can again lead to infertility. And it can go disseminate in females as well, the same as it can in males. So potentially serious repercussions there. What about the incidence? It's difficult to get accurate statistics here. This is not a notifiable disease. We have to kind of make some kind of estimates because, again, it's not something that people like to talk about even. But most of you are in the age group where it's most common. Obviously, the more sexual partners you have, the more likely you are to get it. And you can get it over and over and over again. Just because you get it once doesn't mean you won't get it again. Behind chlamydia, second most common sexually transmitted disease. If you look at the incidence here, I would be interested to see the incidence. Maybe we don't have a very good idea. Before we had antibiotics, I assume the incidence would have been way higher. But we peaked here in the early 80s. Rising up to then, I suppose, the sexual revolution of the 70s or whatever contributed to that. When AIDS came on the scene, people started, had good education about safe sexual practices. People were afraid of getting AIDS, so the incidence has gone down. An uptick lately, I read an article, well, why they think that is. Number one, people aren't as afraid of AIDS anymore. And it pointed to maybe all these apps, these dating apps that people have allow people to kind of hook up easier. I don't know. But incidence, I think, is going up. 2018, that was the latest year that I had figures for. 500,000 cases in the US, likely underreported. And because a lot of times even people don't even know they have it. So it's something to be aware of. What do we do to treat it? Typically, right now, we've gone through a lot of different drugs. Strains become resistant. We have to move on and use a different antibiotic. Right now, a cephalosporin, remember that's a beta-lactam. And I don't even know, I think this is maybe an early generation, but I'm not really sure. In conjunction with either erythromycin, remember that's a macrolide, or doxycycline, which is a tetracycline. So that combination is still working right now. This is a really, check that out sometime. That's a little 2-minute video that the CDC put out just talking about, well, we used these drugs and then the organism became resistant to that, and we had to switch to these drugs, and we switched to these drugs. So resistance is a real problem in Southeast Asia. There's some strains that are coming out that are resistant to everything. So they're kind of focusing on prevention, things like abstinence, monogamy, and condom use. All right, and vaccine, nope, no vaccine. I checked right before class to make sure I was up to date on that. There are none in clinical trials right now. And basically because it is still treatable, it's not a priority right now to get to make a vaccine, but that could change in the future. Our priorities could be different. So, all right. So the other Neisseria that I want to talk about is Neisseria meningitidis. Okay, so reservoir here, just as humans. So it doesn't have an animal reservoir. We're passing it around to each other. And somewhere between 10 and 40% of us are asymptomatic carriers. Okay, so that's pretty astonishing. We'll talk about this. Is meningococcal meningitis is very rare. There was only about 20 cases of this in the US. I think it was last year. It was the year that I had data for. So it's pretty rare. So it's pretty astonishing that a lot of us could actually be carrying this organism, probably in really small amounts and probably just really transiently. It is droplet spread. So that's a direct contact. You have to be, within 6 feet of somebody. It's carried on those larger droplets that you might spit out when you speak or cough. Again, spread by coughing, sneezing. Also by fomites. All right, there was a question on exam 3 about fomites that a lot of people missed. Remember, a fomite is a non-living object. So something like a drinking glass or a eating utensil. Okay, sharing things like that, sharing cups at parties, for example. Okay. The disease that we're talking about here, meningococcal meningitis. So it affects the lining of the brain and the spinal cord, called the meninges. Early symptoms. The early symptoms are kind of flu-like. So things like fever, sore throat, nausea, maybe. And the two that should really be red flags are headache, and not just any headache, but like the worst headache you've ever had, and a stiff neck. Okay, so I can remember taking our daughter to the emergency room once when she was like maybe 4 or 5. She said her neck hurt and she had a fever. And the doctor was like, asked her, do you have a headache? She's like, no. She's like, well, then it's not, we don't need to worry about this. It's like the worst headache you've ever seen, you've ever felt. To diagnose, the best way to diagnose is by doing a lumbar puncture and taking a look at the cerebral spinal fluid. It's not, when those symptoms show up, it's not something that you want to mess around with, because it does can very quickly move into later symptoms due to the release of endotoxin. All right. And this is unusual. Like I said before, endotoxin usually is only released when that outer membrane, when the cell wall breaks down and the cell's dying. Not so with Neisseria meningitidis. It does this thing called blebbing. And that means that it's releasing endotoxin all the time. Okay. And that endotoxin is about somewhere between 100 and 1,000 times more toxic. Okay, so it's being released all the time, and it's really toxic. So very quickly start getting later times. I mean, within like a matter of hours, start seeing petechiae, and this is a rash that starts out kind of reddish and then turns purple and then will turn black. So this inappropriate clotting in the capillaries, those black spots can coalesce and turn, whole areas of tissue black. This hand here would probably have to be amputated. So anytime you see black tissue like that, that's a sign of necrosis and probably not going to be able to save that. Septic shock, again, all this incredible inflammation due to that blebbing, high fever, delirium, cardiac arrest. What do we have here about chances of survival? I think even with treatment, once you get to these symptoms here, we still have a 10 to 20% mortality with treatment. Talk about the treatment in a minute. And about half of patients that survive are going to be left with some kind of permanent disability. So retardation, blindness, deafness, perhaps loss of limb. Okay, so it's a pretty scary disease. We try to prevent this from happening rather than treat it, definitely. Okay, who's at risk? Young children, especially. So children between 6 months and 4 years. Children younger than 6 months have some antibodies from their mother, those IgG antibodies. That starts to wane and they're pretty much gone by about 6 months. This is a T-independent antigen. Okay, so it's the capsule of this organism that, remember, our B cells don't need T cell help in order to be activated, but it's not a great response. And because young children, their B cells are immature, they don't have a very good response. So that's why young children are particularly at risk. Unfortunately, our vaccine doesn't work in young children either, because again, we just can't get them to make this kind of response. The other at-risk age group is between about teenagers and young adults, so about 16 to 23. So especially college students living in dorms, so living in close contact. Anybody with some kind of complement deficiency. Complement is really important, especially in fighting bacterial pathogens. Individuals without spleens. If you don't have a spleen, again, that just makes you more susceptible, especially to exogenous antigens, bacterial pathogens. And just kind of a catch-all, anybody that's immunosuppressed for any reason is, of course, going to be at more risk. Virulence factors, I already talked about the endotoxin. I'll list that here. Again, here, remember, it's more deadly. Otherwise, same as Neisseria gonorrhoeae, it has pili that are specific for the meninges this time. Let's see, I'll write that here. Protein adhesions. For the meninges. And unlike Neisseria gonorrhoeae, it has a capsule. So 5 main serogroups of the capsule, A, B, C, Y, and W135. They went a little bit rogue when they named that last one. So these are the most, 90% of meningococcal disease is caused by those serotypes of capsule. The most frequent outbreak happened about 10 years ago at Princeton. I think there was like 9 students that got sick, and that was actually this B serotype, the one that at that time we didn't have, the vaccine didn't cover. But I looked on the CDC website and they said most often this doesn't happen in outbreaks. You get kind of one here or one there. We haven't had a big outbreak in a while. How do we treat this? The number of different antibiotics that they use to treat it, they need to use one that crosses that blood-brain barrier, like the cephalosporins, the later generation cephalosporins, penicillin, as much anti-inflammatories as we can get into the patient to tamp down that inflammation. Because it is so serious, if you come in contact with somebody that has meningococcal meningitis, they will give you antibiotics just to make sure that you don't contract it. So prophylactically give rifampin or ciprofloxacin. You don't have to memorize that, just you will be given antibiotics, again, if you're exposed. There are several forms of the vaccine available. The most common one is called MCV4. Actually, I don't think they put a hyphen in there. MCV4. And that stands for meningococcal quadrivalent. Okay, so that includes the serotypes A, C, Y, and W135. We had trouble, the B subtype is just not as antigenic, so they had trouble for a long time making a vaccine that would do any good against that B serotype. And that one wasn't as common in the US anyway, so that was left out of the MCV4 vaccine. Now we have a separate vaccine that works for the B subtype. It's usually only given to people that are at risk for it because it's pretty rare. So let's see, what else was I going to say? Oh, it's a subunit vaccine. So we've got, you know, these the pieces of the polysaccharide capsule. And then it's kind of like, remember the malaria vaccine, there was a little bit of hepatitis B antigen to kind of boost the antigenicity. Here they have a little bit of surface protein from the diphtheria bacteria that just makes those polysaccharides, which often aren't very antigenic, a little bit more easily to be noticed. Okay, so we don't give this to young children because, like I said, it doesn't do any good. They don't have a good response to these T-independent antigens. So they're typically given around the age 11 to 12, hopefully a booster before kids leave home and go off to college. Okay. Okay, I got 371 cases reported in the US in 2019. So I underestimated the amount a little bit. It's kind of a seasonal thing. Cases usually peak kind of late winter, January, February, March type thing. Okay. Incidence is really quite low now historically, and they're not sure why that is. All right, questions about meningococcal meningitis? All right, I think we're in good shape here. We're gonna move on to whooping cough. Next week, we'll be moving on to our viral pathogens. I think we're in good shape to cover all those things. I'll try to get that material out and posted as soon as I get it trimmed up a little bit. Like I mentioned, Bordetella pertussis, it's a gram-negative coccobacilli. Okay, so it's not perfectly round, it's not rod-shaped, it's kind of somewhere in between. All right, coccobacilli. Let's see, what else was I going to say? Causative agent of whooping cough. As it's more commonly called, also called pertussis. Also considered non-motile, so no flagella. Extremely hard to grow in the lab. Okay, they're really picky, have to have just the right conditions, just the right media to grow. And it's a strict aerobe. So this is something that lives in our lungs, doesn't disseminate anywhere else in our body because it does need access to that oxygen. Humans are the only known host. Now you get a form of whooping cough in dogs. They call it kennel cough, and that's caused by a Bordetella, a different species. So it's kind of a related disease, but it's important to note we can't get whooping cough from dogs, and dogs can't get whooping cough from us. So it doesn't pass the species barrier there. Some of us are carriers. Okay, so that's important to keep in mind. You and I could be, you know, kind of have transiently some Bordetella pertussis in our nasopharynx right now. So I'll say this again later when we talk about the vaccine, but it's really important. Anybody that's caring for babies should have a fairly recent vaccination for this, because that's when, you know, any of us kind of have the potential to pass it on to a baby, and babies are most at risk of having severe whooping cough. So we'll talk about that a little bit more. Let's talk about what the disease looks like. So the stages of pertussis, in other words, typically about a 7 to 10 day incubation period. And then we have special names for whooping cough for the stages of the disease. So the catarrhal stage, this is considered prodromal. Remember that means that symptoms are typically mild. Catarrhal means inflammation of the mucous membranes, in case you're interested there. That's kind of a foreign sounding word to me. Symptoms here are mild, so they are cold-like symptoms. Runny nose, maybe a little bit of fatigue, a little coughing, a little sneezing. And that will last typically 1 to 2 weeks. So patients aren't particularly sick, so they're out around doing what they normally would be doing instead of home in bed. And this is the stage that it's most infectious. So that's a problem. Again, they're out doing things that they would normally do, being around a lot of people. The paroxysmal stage, this is another name for the illness stage. So this is when the symptoms are peaking. A paroxysm is a violent fit. So this is the stage of infection where patients, you get the hard coughing, and that will present itself a little bit differently depending on the age of the patient. So babies may not cough at all. They may just stop breathing for short periods. It's usually young children that have the cough that's got the characteristic whoop. Adults probably won't have that whoop, or teenagers even. Let me see, I Googled this whoop. Let me see if I can get it without a big long ad here. Oh, loading ad, darn it.
Have you heard? Toys R Us is now at Macy's.
Oh.
This holiday season, find toys
I didn't
every
know there
kid
was
will
Toys R
love
Us
on
stuff.
Jeffrey's Hot Toy List. Only at
Okay.
Macy's.com.
Oh, at Macy's. All right, there, you learned something new. Okay. Okay. I'll post that. Remember. Kind of, if I can figure out how to do it. All right. So the whoop is kind of, the kids cough, and then they cough, and then they try to, you know, suck air back in their lungs. So that's where the whoop comes from. And again, it's usually young children that you see that characteristic whoop. Not so much older patients. They're going to cough a lot, and they may cough so hard that they actually break ribs, but you may not hear that whoop. Lots of mucus, cilia impaired. So, you know, hey, I thought mucus was good. Mucus in just the right amount is good. When you get too much of it, then we have trouble coughing it out. And there's some toxins that make the cilia impaired. So patients have a really hard time just removing debris from the lungs. And that's why they have to cough so hard. Okay, often cough so much that patients vomit. They may not be getting enough oxygen to their extremities, so they may turn a little bit bluish, especially like their lips, under their eyes, fingertips. It's also called the 100-day cough, whooping cough is. So this, even once those toxins start to kind of diminish and patients are getting better, it's still a really, really long disease, 3 months or so, 4 months, till they're better. And plus, because the cilia is impaired, they can be open to other secondary infections like pneumonia or bronchitis. So it's not something that anybody wants to deal with. Again, particularly dangerous for young babies when they get this. Okay, so epidemiology, how is this spread? Who gets this? Droplet spread. So direct contact, it's not considered airborne, or at least most commonly wouldn't be. So you have to be within a meter of somebody. It's those large droplets. The organism's going to colonize, again, just the trachea, the bronchi, places where the organism's going to have easy access to oxygen. Before the vaccine, and before we had antibiotics to treat it, in the 1940s, 200,000 children sick per year in the US, and about 9,000 of them died. So we've come a long way. In the US, in 2012, I couldn't find figures any sooner than that, 20 deaths. So thanks to the vaccine, thanks to antibiotics, we've come a long way. Worldwide, more like 200,000 children die. So, places where maybe the vaccine isn't as accessible. We had a spike here in 2012. And that, interestingly enough, that was the year my son had gone to orchestra camp in Howell, Michigan. And when he came home a week later, we got an email that said, we hate to tell you this, but somebody in your son's cabin came to camp with whooping cough, and somebody else in your son's cabin is sick with whooping cough. So, look for these symptoms, whatever. It was a proud mom moment because I had just gotten him vaccinated on his 12th birthday. So my son didn't get it. But both of those kids have been vaccinated as children. So part of this, peak here is that the vaccine is wearing off by early adolescence. So we'll talk a little bit about that. A combination of people just kind of not vaccinating their kids. Maybe there's some antigenic variation there as well. But it's not a disease that's going to go away. Okay, much less incidence has gone way down, but it's probably not going to go away. Just a few virulence factors that I want to talk about. I cut this back quite a bit. You'll see more virulence factors talked about in the book. But I wanted to mention especially one exotoxin, easy to remember, pertussis toxin. There are some other toxins, and they all sort of have a little overlapping function. So I thought we'll just mention pertussis toxin. It's vitally important that the Bordetella stick to a certain kind of epithelial cell, the ciliated epithelial cells in our respiratory tract, because they actually don't invade those cells. They just need to stay right there. So there's lots of toxins and adhesins that this organism produces. And these toxins not only help them to bind, but are really going to impair our innate immunity, like our phagocytic cells. Also increases mucus production and stops cilia. So again, that's why patients have to cough so hard. One adhesin in particular is called filamentous hemagglutinin. I wanted to mention that one because that's part of what we use for the vaccine. Again, just acts somehow to kind of make it killing less efficient by our phagocytic cells and helps it adhere. It has that little different form of endotoxin, lipooligosaccharide. Remember, it's a gram-negative. Not nearly as toxic as what we see for Neisseria meningitidis. Okay, just released when the organism dies. All right, so how do we treat? What's the vaccine look like? We treat with a number of different antibiotics. Here's just a few of them. I think azithromycin is more commonly used these days than erythromycin because it has a few less side effects. Again, don't memorize, just we give antibiotics. Interestingly enough, the antibiotics really don't speed up the convalescence time, but because it's really the toxins working that's really kind of prolong the illness. If you do give we do give the patient antibiotics though, because it makes them less likely to transmit it when they're coughing. So we give antibiotics and then just kind of have to wait it out, basically. We do have a vaccine. And if you remember, we talked about this vaccine a few weeks ago. We used to give a whole cell vaccine, and we put that pertussis whole cell together, a killed cell, obviously, together with diphtheria and tetanus toxin, I believe. Those are toxoids, but we administer those together. In 1996, we switched to a subunit or an acellular vaccine, because then we just have parts of the pertussis toxin and that one protein, filamentous hemagglutinin, just kind of parts of the cell that are antigenic and not the whole cell. So we leave out the endotoxin. All right, so most of you probably had this one as children. You see the acellular pertussis there, less inflammation at the sites of injection. So it has to be given a number of boosters, 4 doses, in order to try to provide some protection when babies are little. Women should be vaccinated in their 3rd trimester. Okay, babies that do come down with pertussis, they almost find some member of the household that's been coughing for a while and probably had some undiagnosed whooping cough. So really important for people that are around babies a lot to get a pertussis booster. The problem with the subunit vaccine, people are more likely to get it, but it doesn't provide as good a protection. We're finding some waning immunity. Really, protection only lasts, maybe less than 10 years. So, you and I that had it as babies and maybe not since then are not protected. So keep that in mind if you, again, plan to be around kids. Really very little drug resistance here, so that's not a problem. But again, a difficult disease. Okay, that is as much as I wanted to get through today. So stick around if you have any questions. Otherwise, we'll be on to viruses on Tuesday. Have a good weekend. Go Blue.